Okay, class, let me welcome to you to this lecture. And like technology has made everything easier, but then also some technological errors can occur. Okay, so am I audible to you, to all of you? Okay, somebody answer. So if I'm audible, then I'll just continue like this. Okay, good morning everyone. Okay, fine. So many of you have answered to me. So okay, today we are going to begin this lecture. The topic is complications of otitis media. Okay, so till now you should have already learned so many things about the ear and the anatomy and other things about the ear. So the topic that I'm going to teach you today is a very important topic, and almost always you are asked some sort of questions from this topic, from this class. Well, this is a long topic, and I intended to start it a little earlier, but as you're aware, because of the technical errors, technical problems, we are only 10 minutes left. So today we are going to be, we are going to go through the slides a little faster. And if you have any questions, then you can, write that in the chat box. Okay, give me a second, right? I can't find the chat box. Okay, where's the chat box? It's here. Okay, so like increasing the time by 10 or 15 minutes or 20 minutes won't be a problem, I think. But I was told that the Zoom meeting may stop after 40 minutes. But sometimes they give us bonus time. So let's see. Okay, fine. Okay, I agree with you all. Okay, we will try to go in normal pace, and if something is left, then we'll try to cover it in the next class. All right. So now let us begin. Complications of otitis media. Now, there are many forms of otitis media, right? Like otitis media with effusion, acute otitis media, chronic otitis media. So this otitis media that we are going to talk about especially means acute otitis media or chronic otitis media. All right. So what do you understand by complications of otitis media? So regarding this otitis media, I need to tell you one story, or maybe it is a joke. So this otitis media is so common that it is regarded as normal in many parts of the world. Okay, when I was doing my residency, there was one joke, like one father brought his son to the OPD. जोकहरू इङ्ग्लिसमा भन्दा नेपालीमा भनेको राम्रो सुनिन्छ है, त्यही भएर चाहिँ के भन्दाखेरि एउटा बुवाले आफ्नो छोरोलाई हस्पिटलमा लिएर आयो, ओपीडीमा लिएर आयो। अनि उसले भन्छ, ल डाक्टर साहब मेरो उसको चाहिँ छोरोको कानै बगेन है। अनि भन्न खोजेको के हो भन्दाखेरि यति कमन छ हैन, र यो यति सिम्पली लिन्छ हैन, र डिजिजको रूपमा नलिएको कारणले चाहिँ हैन, कान बग्नु भनेको त नर्मल हो, कान नबगेको चाहिँ किन बगेन एब्नर्मल हो भन्ने बुझिरहेको हुन्छन् है। बट द्याट इज नट द थिङ. So chronic otitis media or acute otitis media is a real disease, and the complications of otitis media can become severe, and they can even be fatal. And even as clinicians, sometimes we undermine the severity of this disease. Okay, so how do you define? How do you define complications of otitis media? Okay, so it is here. Give me some time. Okay, now it appears better. Okay, so infection is spreading beyond mucoperiosteal lining of the middle ear cleft to involve bone and neighboring structures like facial nerve, inner ear, dural, sinuses, venous sinuses, meninges, brain tissue, and extratemporal soft tissue will cause complications of the otitis media. So otitis means ear, media means the middle ear. So the infection is spreading from middle ear to anywhere in the periphery will cause complications. Now, how will you know that these are the features of complications? Okay, there will be severe otalgia, and there will be pain around the ear. There will be vertigo, there will be nausea and vomiting. Similarly, headache, blurred vision, projectile vomiting, fever, neck rigidity, drowsiness, irritability, facial symmetry, otorrhea, retroorbital pain, diplopia, ataxia. Okay, usually, when the patient comes to you with ear discharge, he won't have any symptoms like this. There won't be any pain, and there won't be any swelling or anything like this. But whenever the symptoms and the signs are like this, then you must suspect that this otitis media has been complicated, so, or some complications have developed. Like whenever there is fever, neck rigidity, irritability, you need to suspect meningitis, which is also a complication of otitis media. Okay, similarly, facial asymmetry, because sometimes facial lobe may be damaged in otitis media as a form of complication. Okay, so how do we classify complications? Okay, this is not the classification of otitis media. This is the classification of complications of otitis media. So the complications can occur in the brain. If it is like that, then it is called intracranial, and it can occur outside the brain. So intracranial and extracranial. And then again, extracranial has two forms. So it can either occur only in the temporal bone, or it can occur outside the temporal bone. Okay, so when you classify, you can just make three classifications: intracranial, intratemporal, and extratemporal, or then make two classifications and again divide into two parts. So, because we are going to talk so much about temporal bone, so I'll tell you, you need to know that the temporal bone has four, but some books also say that there are 5 parts. So the 4 parts are the mastoid, the part that lies behind your pinna, and the squamous part, the petrous part, and the tympanic part. And sometimes the styloid bone or the styloid process is also termed as a part of problems. So I lost the connection. Okay, I'm being told that my internet connection is unstable. So that is why. Oh, okay, guys. What can you see here? Can you see me, or can you see the presentation, the slide? झन् आज धेरै पढाउने भनेको यो झन्झटै झन्झट हुने रहेछ त. So you can only see me, but okay, now let me share the screen. Okay, I hope you can see the slide now. Okay, so sorry for interruption. Okay, whenever we are using something controlled by internet, this is bound to happen. Okay, all right. Okay, so now there is slide. Okay, now full slide. Okay, so this should be from like this. Talk about today. So this is where the pinna or the ear and all parts of the ear lie. Okay, this is the cochlea, this is the labyrinth. Hazur? And this is the dura mater, the arachnoid matter here. Abscess, subdural abscess. So these are all the intracranial complications. So outside the cranium, okay, you'll get the temporal bone. So if there are issues or complications in the labyrinth, so there will be labyrinthitis. If the facial nerve is affected, there will be facial nerve paralysis. Similarly, lateral sinus thrombophllebitis. And in the mastoid part of the temporal bone, there will be mastoiditis. Okay, what all of them one by one. Okay, so What are the intracranial complications? So, is from this slide, we can see that there can be extradural abscess, subdural abscess, meningitis, brain abscess, lateral sinus thrombophlebitis, and otitis hydrocephalus. And intratemporal complications, acute mastoiditis, coalescent mastoiditis, mass mastoiditis, facial palsy, labyrinthitis, labyrinthine fistula, and apex petrositis. Okay. And similarly, there are extratemporal complications like post-auricular abscess, visual sepsis, zygomatic abscess, and retromastoid abscess. Okay, all of these names are very important, and be assured you'll always be asked one or more question from this topic. Okay, and as MBBS students, okay, after you finish your MBBS course and you are in the PSC or elsewhere, looking after the patient's OPD or the emergency, and if you suspect any cases like this, then you need to be very prompt and refer the patient or it can be severe complications, even the patient can collapse. Okay, now what are the factors affecting the development of complications in otitis media? So the pathogen factors, okay, there is little that we can do about this. There is high virulence, there are some high virulence bacteria, and because of the injurious use of antibiotics, so the organism they have developed resistance. Okay, so because of these things, the pathogen factors, there can be more events of complications. Similarly, there are patient factors. Okay, so it is more common in the young people, young children, and in the elderly. Similarly, those who have the people of your age and my age. Similarly, the people who have chronic diseases like diabetes mellitus or tuberculosis. Similarly, those who are from the poor socioeconomic status. Because of this, there is malnutrition and many other factors. So such people more frequently develop complications. Similarly, those who lack health awareness. And similarly, there are some fusion factors like non-availability. Okay, so there is little that you can do about non-availability. Okay, in the far-flung areas, or even the people who are not medical personnel, so it won't be possible for them to diagnose complications in time, and in such cases the disease will progress and the patient may die. Similarly, even in the higher centers like here or in the periphery of Chitwan, Kathmandu, or any other place, so there has been rampant use of antibiotic. So because of this rampant use of antibiotic, the organism they have been developing resistance, and because of things there are more chance of developing complications. And this also very important, error in recognizing dangerous symptoms and signs. Okay, this is indeed something like negligence, or maybe. So the main aim of this class is to teach you to recognize these dangerous signs and symptoms, so that you treat those diseases promptly if you are very much sure or you're very confident of treating that, or even if you are not very confident of treating that disease in your center, in your PSC, or in your private clinic. So you should be able to refer that patient infection of the middle ear. So how does infection spread to the cranium, okay, into the brain and to the other parts of the temporal bone? So there are these routes of entry. Okay, class. So if you have any problems or if there is any issues with the slides or the presentation, then you can send it in the chat box. In a time and again, I'm checking the chat boxes. All right. So by bone erosion. So you have not yet been taught about cholestoma. Cholestoma is such a disease which erodes the bone, and it is dangerous. Okay. Even otitis media, acute otitis media and chronic otitis media, mucosal type, they are dangerous. But this is more dangerous because it erodes the bone and it forms a pathway for the entry of microorganisms from the middle ear. The route of entry is retrograde thrombophlebitis. Similarly, there are some anatomical pathways. Okay, these are the normal anatomical pathways like oval window, round window, okay, internal auditory canal, suture line, cochlear and vestibular aqueducts. Similarly, there can be congenital bony defects in the facial canal or in the tegmen plate. And then there are some acquired bony defects. Okay, yeah, there's breaking my voice. That's right. Sometimes, like you are not able to see that, but on my screen, it appears your internet connection is unstable, and so maybe during that time, there is a break in my voice, as Diksha has noticed. From middle ear to the other parts of the uh, temporal bone or the brain. So look here, the roof of the temporal bone, this is the middle ear, and what lies above is the tegmen tympani, okay? And this tegmen tympani, this is the partition between the brain and the temporal bone, and this has been eroded. And mastoiditis. Okay, so how does mastoiditis develop? So first there is the blockage of Otitis. So by now you should be knowing what is Otitis because we have already talked about. We have already talked about. The anatomy of the middle ear. So because of the Otitis blockage, there is failure of the drain of ear cells, coalescence of small ear cells to form cavity, and empyema of mastoid cavity. So here is a diagram. So this is a diagrammic representation of the middle ear and the mastoid ear cells. Okay, so the mastoid ear cells look more or less like a beehive, but here this is the Otitis. Otitis connects the antrum. Okay, this antrum is the largest mastoid ear cell. More class, sorry. Okay, and this Otitis, it connects the middle ear with the mastoid ear cells. Okay, and when there is blockage, so what we get is this. Okay, status of secretions and okay. So what are the clinical features and the investigation that are required to be done? Okay, otorrhea, if it is lasting for more than 2 weeks and there is ear pain and deafness, so suspect mastoiditis. Okay, mastoid reservoir sign. Okay, this is a very important terminology. So what happens is that uh, under headlight or any other illumination or microscope, you clean the or you mop the uh, is up in the external canal. And then there is the sagging of the posterior superior wall. Okay, this happens especially in acute mastoiditis or coalescent mastoiditis. And it is due to periosteatis of the bony wall between antrum and the posterior external auditory canal. And similarly, there is ironed out appearance. Okay, and mastoid tendon is present, and we also need to look for mastoid cavity in X-ray and the CT scan. Okay, so these are the three terminology or three phrases that are very important when you mop the ear, and then again after some time, because of the pulsatile nature, there will be filling up of the pus in the canal. Okay, so I have more, and then there is mastoid tenderness. Okay, so mastoid. So to elicit mastoid tenderness, what you need to do is to press over the tip of the mastoid. Okay, now they are saying that I have only 10 minutes left. Okay, let's see what happens. Okay, this is the mastoid reservoir sign that I was talking about. Okay, okay, this is the malleus, and there is the perforation of the tympanic membrane, and there is pus coming from here. Okay, when you clean it out using suction or mop, then this will again get filled up. So this is mastoid reservoir sign, and this is the posterior wall of the external auditory canal. And because the mastoid lies in the close proximity of this part, there is a sagging of the posterior wall of the external auditory canal. And this is a very important feature. Okay, and look here, normally if you see in your ear, behind your pinna, you can see there is the groove. But here the groove is obliterated. And so this sort of feature, if you see something like this, so this is called iron rod appearance. Okay, so this is also diagnostic of mastoiditis. Now, and then you send the X-ray, and here you do not see any beehive-like appearance. Okay, you see a large mastoid cavity. Furunculasis from mastoiditis. Okay, you do not need to go into detail. Okay, just you need to know that in case of furunculasis is localized inflammation of the external auditory canal. So whenever you press over the tragus or you move the pin on this manipulation in case of mastoiditis. All right, and similarly the discharge, the type of discharge is different because the mucus producing cells are not present in the external auditory canal. The ear discharge mastoiditis is mucopurulent, but it is serous or purulent in case of furunculosis. Okay. And in case of furunculosis, there is no history of otitis media, there is no deafness, and there is no sagging the ESC wall, and there is no TM congestion. TM is normal. Whenever TM is normal, okay, it is not otitis media. All right. Now treatment. Okay, this disease can become very dangerous. Okay, so it requires urgent hospital admission, and then you give broad IV antibiotics, broad spectrum IV antibiotics. And if there is no response to medical treatment in 48 hours, so there can be development of new complications, or there can be SUB-PERIOSTEAL abscess. So in such cases, we need to drain the pus by myringotomy. So in myringotomy, so it will be, okay. So we make a puncture in the tympanic membrane so that the pus it drains out. Similarly, over the mastoid region, if there is swelling or the SUB-PERIOSTEAL abscess, we need to make an incision and drain the pus. And sometimes cortical mastectomy may be required. Okay, but these days surgical intervention is not required. Okay, so almost always antibiotic therapy can cure the disease. Okay, SUB-PERIOSTEAL abscess and the fistula. So anything that is below the periosteum in the mastoid region is SUB-PERIOSTEAL abscess. So it is the production of pus under tension, and there is hyperemic decalcification and osteoclastic resorption bone. There can be SUB-PERIOSTEAL abscess, and the periosteum can be penetrated, and also the skin will be penetrated. Mastoid bone, but whenever the infection it spreads beyond that and around the periosteal covering of the mastoid and the skin, then it is called SUB-PERIOSTEAL abscess. And if the skin is involved, then there is fistula. Okay, so look here, this is the normal side, and here the pus has been developed under the skin. Look here, SUB-PERIOSTEAL with fistula, it is a dry tract. There was a discharge earlier, but now because of antibiotic therapy and other things, it got relieved. It's such a big fistula, and it is connected. It may be connected to the antrum. Okay, and look here, there is some discharge. This is the wet type that occurs in relation to the mastoid abscess. It can have various extensions, and there are various conditions that are named on the position of the swelling or the pus. So There can be post-auricular abscess, there can be visual abscess, there can be CTLS abscess, there can be zygomatic abscess, Luke's abscess, retromastoid abscess, and peripharyngeal and retropharyngeal abscess. So these must be so many new terms for you, but you need to know this, okay? So examiners, they are very happy to ask you about visual, CTLS, and Luke's abscess especially. And in Viva, you need to tell, you need to, at least to tell them about the location of these abscesses. Okay, so this diagram is the summary of what we are going to study next. And the zygomatic abscess is here at the zygomatic process, and the visual abscess just below the ear and beneath the sternocleidomastoid muscle. And this is the post-auricular abscess, retromastoid abscess, and by C we understand CTLS abscess. Okay, so different books, they have different descriptions about the CTLS abscess. Some books say that the CTLS abscess occurs here, and some other books, they say that the CTLS abscess occurs at the occipital region. Okay, so whatever you answer in the exams, it will be considered as a right answer. Okay, so now I'll let the diagrams to do the talking. Okay, so this is the post-auricular abscess, and look at the pinna, how it is pushed out. Okay, this is the so whenever you're going to examine the ear, make sure you examine the preauricular area and the post-auricular area. Okay, during the internship, I find many students who just pick up the otoscope and insert it inside the ESC and try to look for the tympanic membrane, but that is not the real technique. Okay, first you need to begin by inspection, okay, and the areas that lies outside, and then only you proceed to the areas that lies inside. Okay, so we'll talk more about the examination part and these things in your clinical classes. If we can have that later in this year. Okay, look here, the pinna is pushed forward and downwards and also outwards. Now basals and CTLS abscess. So only know the definition. Next, swelling over the sternocleidomastoid muscle. Okay, so basal abscess occurs here, and CTLS abscess is next swelling over posterior belly of the digastric muscle. Okay, around this area, it is called CTLS abscess. Okay, look here. This is how basal abscess looks like. So whenever there is basal abscess, there must be otitis media. Okay, so these things, they occur only when there is otitis media. All right. So the differential diagnosis is suppurative lymphadenopathy of upper deep cervical lymph node. Okay, very common. Parapharyngeal abscess, which is occurring not in connection with otitis media. Similarly, the abscess of the parotid tail, infected branchial cyst, and internal jugular vein thrombosis. Okay. So whenever you are taught about the differential diagnosis, make sure you remember all of them because they are quite important. Okay, now the Luke's abscess. It is the swelling in the external auditory canal. Zygomatic abscess, swelling anterior superior to pinna and upper eyelid. Retromastoid abscess or the occipital abscess has also been called as CTLS abscess in many references. Okay, and similarly parapharyngeal and retropharyngeal due to spread of pus along the ichthyosium tube. Okay, start another session. Okay, what time is it? But we still have plenty of time. And you mean to say, do you mean to say that because Zoom only allows 40 minutes, so you start on the session? So just a while ago, there was one dialog box and it asked me to upgrade. So I clicked upgrade. Okay, let me minimize this and see. Okay, class, sorry for disturbance. Okay. Okay, I have started on another session. All right, and I hope to. तपाईँले हेरिराख्नु भएको थियो त ल हेरिराख्नु भएको थियो त ल सिधै होइन अहिले अर्को सुरु भयो अब टाइम एक्सटेन्ड भएन हैन मानेन अनि त्यसपछि अर्को सेसनै सुरु गरे है कतिजना 53 जना 54 है Okay, class, you answer me in the chat box. So, okay, are you able to see the new session? Okay. So, okay, class, let us continue from where we had stopped. Mobile ma chai garnu parne raheछ क्या side by side थाहा हुन्छ नि Okay, so this is the retromastoid abscess that we are talking about. Okay, and this is the pinna, and look here, the big swelling. Okay, and because there is so much of abscess, we need to do ENT, incision and drainage. Now, this is also a very common phrase or very common symptom that you are asked in your live exams. So you are most always asked, what is Gradinus syndrome? Oh yeah, so it is up to 10 AM, but 5-10 minutes of boarding on us. Sorry. We will try to finish, complete it. Okay. So persistent otorrhea, despite adequate cortical mastoidomy, retroorbital pain, and diplopia. So you need to remember it by 3 Ds. Okay. Discharge, deep-seated headache, and diplopia. So that will give you Gradinus syndrome. Okay. Okay, we are going to go a little fast today, right? Okay, so this is the area that is affected because of this nerves. There is persistent otorrhea and retroorbital pain and convergent squint. Okay, we are not going to go deep into this. And so, what is the etiology? Okay, of Gradinus syndrome? Coalition mastoiditis involving Petrus effect along posterior superior and inferior tracts in the relation to bony labyrinth. So the diagnosis is by CT scan, temporal bone for bony Otitis, and MRI for bone marrow and pus. Okay, and the treatment is by modified radical mastoidomy and the clearance of Petrus effect cells. Okay, so look here. So now we are talking about the petrositis. Okay, petrositis is also one of the complications of otitis media, and this part is affected. All right. So these days, surgical we do not go for surgical intervention. First, we try to treat the disease by medical therapy. Okay. So this diagnosis is a summary of what we just studied. Okay, this is the middle ear. Suppose this is the middle ear, and if it is going to the extra-auditory canal, it will cause lux abscess and zygomatic abscess. Okay, and if it is going interiorly and downward, Otitis abscess, and inferior to the pinna, episodes abscess, then post-auricular abscess, behind retromastoid abscess, retropharyngeal and parapharyngeal abscesses. Okay, just to give you a general idea. Now, labyrinthitis. Okay, this is a very important complications because it is different from other abscesses that we just talked about. It is the inflammation of the endosteal layer of the bony labyrinth. The root of infection is a round window membrane, preformed opening, especially caused by SUB-PERIOSTEAL surgery, and retrograde spread of the meningitis via internal acoustic meatus or aqueducts. So there are different forms of labyrinthitis: circumscribed, diffuse serous, or diffuse suppurative. We are not going to go into detail. We are only going to go into the treatment. So bed rest is suggested. The affected ear is kept up, and the head movement is avoided. Similarly, labyrinthine sedatives are given like prochlorperazine and cinnarizine. So because when the labyrinth is involved, the patient will complain of dizziness or vertigo. So labyrinth sedative is required. Similarly, broad spectrum IV antibiotics are given, and there are many surgeries that can be done, like modified radical mastoidomy to remove the infection. Similarly, if there is open labyrinthine fistula, then it needs to be covered by temporalis fascia. And if the fistula is less than 2 mm, the matrix is removed. But if it is more than 2 mm, then the matrix causing the erosion is not removed. Okay. So look here, this is the CT scan image, and it shows lateral semicircular canal fistula. So we don't need to go into detail of this. Now, facial lobe paralysis. Okay, you need to know that facial lobe paralysis is a classmate. Okay, facial lobe paralysis is a very it is very commonly seen in ENT OPD. The most common cause is Bell's palsy, but facial paresis also occurs due to is a complication of otitis media. Okay, so within the first week, there is facial paresis due to the nerve sheath edema. After 2 weeks, there is the bony erosion, and then there can be lower motor neuron palsy, and it is very common in tubercular otitis media. So the treatment is the removal of the disease by modified radical mastectomy, and sometimes the facial nerves need to be decompressed. Now, with this, we have completed the extracranial complications of otitis media, and now we are going to talk about intracranial complications. So the intracranial complications, we can do it very fast because we do not have enough time, and similarly these topics or these diseases will be covered by the Department of Surgery or the neurosurgery, because this like whenever there are these conditions, these are taken care by the neurosurgeons. Okay, so first we are going to talk about meningitis. Okay, so in meningitis, there is high grade persistent fever with rigors, severe headache, and neck stiffness. Okay, this is very important. Neck stiffness, irritability, drowsiness, confusion, coma. Neck rigidity is positive, and there are these two important signs that you need to know: chronic signs and OTOGENIC signs. And I'm sure you have learned about this in the third year already. And then there can be papillodoma, and lumbar puncture is almost always done whenever you suspect a case to be meningitis. So there is increased cell count, increased protein, and decreased sugar. And the choice of antibiotics is IV ceftriaxone, metronidazole, and more in the class more followers, right? And so the treatment is neurosurgical treatment. So it is usually done by the medical therapy. Okay, and once the patient is neurosurgically stable, then only the patient is handed over to the ENT department, and where we perform the mastectomy so as to remove the disease, because the main pathology lies in the temporal bone. Okay, so now there are two different schools of thought. In some countries, they say that, okay, neurosurgical intervention, okay, for example, if there is brain abscess or something like that, so the neurosurgical intervention and the ENT intervention, they need to be done in the same sitting together. But in the developed countries, it is usually said that, first the patient is to be made neurosurgically stable by the Department of Neurosurgery, and then only when the patient is stable, then further surgery is planned on the temporal bone of the patient. Okay, so you must have already read it in third year. So you test for the neck rigidity, and this is how you elicit chronic signs. Okay, you flex the knees, and then rigidity signs. When you flex the neck, so there is the movement of the knees. Okay, then autogenic brain abscess. Okay, brain abscess can occur because of the like many other reasons, but in 50 to 75% of the adult brain abscess and in 25% children, the cause for brain abscess is mostly autogenic. So whenever brain abscess is found out by neurosurgical department, they usually consult with ENT so as to rule out any pathology in the ear. Okay, so temporal lobe abscess to cerebral abscess is in the ratio of 2:1, and the route of infection is direct abscess. And in I had shown you one slide where the tegment plate, okay, the bony plate separating the temporal bone and the brain is eroded, okay, and via the Trotman's triangle, okay. And whenever the infection is spreading by Trotman's triangle, then there is the cerebral abscess, and the infection can also spread by retrograde thrombophlebitis. Okay, so this is the Trotman triangle that we are talking about. Okay, superiorly there is superior petrosal sinus, posteriorly there is sigmoid sinus, okay, here, and internally there is the solid angle. Okay, this solid angle is formed by the semicircular canals. And the importance of this Trotman triangle is it is the pathway to posterior cranial fossa from mastoid cavity. Okay. Now stages of brain abscess. So we are going into short in this. Okay, invasion or encephalitis, it occurs in the first 10 days. Then localization or latent abscess from 10 to 14 days. Expansion or manifestation of abscess. So after 14 days, and this leads to increased intracranial tension and focal signs, and termination or abscess rupture, and this leads to fatal meningitis. Okay, so these are the 4 stages. So encephalitis, and then there is a localized abscess formation, and the abscess is expanding here, and ultimately the abscess is ruptured. Okay. Now, what are the investigations that you do? Okay, so in any cases of brain, you go for CT scan of brain, and also the temporal bone, because in 50 to 75% of adults, the cause lies in the temporal bone, and in 25% of the children, the cause lies in the temporal bone. So always order for CT scan of brain and temporal bone with contrast. Okay, and then you can also do MRI for brain. Okay, so to differentiate between cause, abscess capsule, edema, and normal brain, and to find about the spread of ventricles and short erectile space. Okay, and you need to avoid lumbar puncture to prevent coning. Now, this is the temporal lobe abscess is in the CT scan, and this is the cerebral abscess. Okay, and what is the medical treatment? So, high dose broad spectrum IV antibiotics are given, ceftriaxone, metrorhizinazole, and gentamicin, and IV dextrona or dextromethasone is given 4 mg 6 hourly to decrease edema, and mannitol is given to decrease intracranial pressure, and similarly antiepileptics like phenytoin sodium can be given, and antibiotic ear drop and oral toileting is also done. So oral toileting can be done by suctioning of the external canal and trying to remove as much as possible that can be removed by suctioning, as I said, and or by mopping. Okay. So, you know, when the brain abscess are developed, the neurosurgeons, they may plan to do the surgical treatment. The surgical treatment can be repeated borehole aspirations, and the best treatment is excision of brain abscess with the capsule. Okay. So, repeated borehole aspiration has many benefits, like this is a small procedure, and like there are lesser chances of complications. But this, whenever you are planning to remove the brain abscess with the capsule, this is a very large procedure, and this requires considerable surgical dexterity, and it has many complications and can result in neurological deficit. Okay, similar open incision evacuation and radical mastectomy after the patient becomes stable. Now, similarly, another complication is lateral sinus thrombophlebitis. Okay. This is also a very common complication. Okay, so lateral sinus means sigmoid sinus plus a transverse sinus. So the erosion of the sigmoid sinus plate, preauricular abscess, inflammation of the outer wall, endophlebitis, mural thrombosis, occlusion of the sinus lumen, intersinus abscess, and all of this propagate infection through the thrombus. Okay, and this will cause lateral sinus thrombophlebitis. Okay, this is the lateral sinus. Okay, so what are the clinical features? Okay, a remittent high fever with rigors. So you need to know this word, picket fence fever. Okay, pitting edema over retromastoid area and occipital bone due to mastoid hemicentric vein thrombosis, and this is called Grissner's sign. Similarly, there is tenderness along internal jugular vein, headache, and anemia. Okay, so how do we get this word, picket fence? Okay, so in USA and Europe, you see that the area, the house is bounded by a fence like this. So this is called the picket fence. So in picket fence fever, there is high fever and it is of swinging type. So there is chills, and fever precedes the chills, and the temperature subsides with sweating, and each spike of fever is due to the release of fresh septic embolus. Similarly, there can be retinal vein dilatation and optic disc edema. Okay, investigations. Okay, lumbar puncture, CT, MRI angiography, blood culture, sensitivity of ear discharge, and peripheral blood smear. Okay. Now treatment. Okay, radical mastectomy, removal of the disease, needle aspiration to confirm diagnosis, sinus wall is incised, infected clots removed, and abscess is drained. And then you give higher antibiotics. Anticoagulants need to be given because there is the thrombus formation, and sometimes internal jugular vein ligation is done, and if there is anemia, then you need to do blood transfusion. Okay, so extradural abscess. Okay, this is one of the intracranial complication. Okay, this is the skull bone, and this is the dura. And anything that is occurring outside the dura is the extradural abscess. Okay, so these topics will be taken in detail by your neurosurgical faculties. Okay, it is commonest otogenic intracranial complication, and the collection of pus is between skull bone and dura of the middle or posterior cranial fossa. Okay, in majority, it is asymptomatic, and it is substituted in case of profuse intermittent postnatal purulent, low-grade fever, okay, recurring meningococcal meningitis. CT scan is diagnostic, and you give antibiotics, which usually improves, and sometimes surgery is required to drain the pus. Okay, this is how extradural abscess looks like in CT scan. Similarly, subdural abscess. Okay, so it is below the dura mater, in between dura mater and arachnoid mater. Okay, collection of pus between dura mater and arachnoid by erosion of bone and dura mater by retrograde thrombophlebititis. Okay, and again here CT scan shows subdural abscess. The treatment is mostly the same: IV antibiotics and surgery. Okay, and as ENT surgeons, we prefer to do mastectomy only after the patient becomes stable. Okay, this is how subdural abscess looks like. Okay, then otitic hydrocephalus. Okay, this is also known as benign intracranial hypertension or Simon's syndrome. Etiology is associated lateral sinus thrombophlebititis, obstruction of several venous return, and superior sagittal sinus thrombophlebititis, and decreased CSF reabsorption. The clinical features are severe headache, vomiting, blurred vision, papilledema, optic atrophy, adducens palsy, and diplopia due to increased intracranial tension. Now the investigations, like with other diseases of the intracranial complications, lumbar puncture, okay, CT scan, and treatment is again similar. Okay, IV antibiotics and MRN. Okay, okay, and CSF pressure decrease so as to prevent optic atrophy, and IV dexamethasone is given, mannitol is given. Okay, and lumbar puncture, this can be done, or lumbar drain is also done to decrease the pressure. Okay, so this sums up the complications of otitis media. Okay, and now we are at the end of the class. It is already 10 o'clock. So before ending the class, I must tell you that this may have been overwhelming for you, because we have talked about so many diseases. But you need to know that all the intracranial complications, they are the part of neurosurgery. So you may have studied earlier in the neurosurgery classes, or if they have not been taken in neurosurgery classes, then it will be taken later too, very in detail. Okay. So what you need to know is these intracranial complications, they occur mostly due to the pathology in the temporal bone or in the ear or in the middle ear. Okay. So so you need to be able to diagnose it in plenty of time, so that, because all these intracranial complications, they can be fatal. Okay. And but if you diagnose these conditions in time, and if you give treatment or refer those patients within time, then the patient, they can survive. So apart from these intracranial complications, the extracranial, either intratemporal or the extratemporal complications, you need to know about them in detail. Okay, you need to know all those names like visual abscess, Otitis abscess, or Lux abscess. Okay, and you need to know how the infection travels. Okay, what are the causes of the complications, and what is complications exactly. And similarly, when you need to suspect that the ear has developed complications, otitis media is a very, very common disease. Okay, there was no research that was done several years in Nepal. So it says that the prevalence is as high as 7.5%. Okay, that is very high. But not all the patients with otitis media develop complications. But whenever there are complications, make sure you diagnose it in plenty of time. Okay, someone has created a slide. This lecture is recorded, and maybe later on you will give on the video class or the lecture. Seems is collaborating on that. CT scan र MRI को के फरक हुन्छ? Okay, CT scan and MRI, they are very different, right? Both are radiological investigations. अब त्यसको बारेमा त 4-5 वटा क्लास नै हुन्छ होला. Some other doctor will take that class, right? But basically, when we are looking about the bone, when we need to know more about the bone, we order for CT scan. But when we are more concerned about the soft tissue, then MRI is given. CT scan ma radiation huncha, MRI ma radiation hundaina. That is also important, right? MRI ma if the patient has a pacemaker or some metal, okay, MRI cannot be done. All right, and mostly, so these are the differences between CT scan and MRI. पछि just मिल्यो भने चाहिँ अब हामीले पनि भन्नु के कुराहरु in relation to ENT. Okay, so class, this sums up. Okay, Gratinescu syndrome, हैन अब okay रित बठार है. So बुकमा हेर हैन, तर अहिले बेसिकली तिमीले जान्न पर्ने 3 Ds है, ABCD D को D. So one D is for discharge, another D is for diplopia, and another D is for deep-seated headache, right? So these 3 Ds will comprise of Gratinescu syndrome, right? What do you understand by deep-seated headache? What do you mean by discharge? I know in your detail that I have already told you, right? So anything else that you want to ask? So I have one question. So throughout the class, what problems did you suffer? Like any problem with the voice, the clarity of the voice, or any background noise? And okay, there was one issue. The session ended after 40 minutes. That is one thing, right? Okay, one student has asked a question on what basis we choose antibiotics. So here you need to know is that what you need to know is antibiotics, broad spectrum antibiotics are preferred. Okay, so ceftriaxone is the most preferred antibiotics, and along with ceftriaxone, we also give 2 or 3 antibiotics like metronidazole and gentamicin. Okay, thank you, Loya, for your comments. Okay, fine. So it is already 10:02. So shall we stop now? Or if you have anything to ask, or if you have any suggestions to make? किनभने मलाई के लाग्छ हैन, in 2020 अब हाम्रो चाहिँ हामीले चाहिँ यसरी नै हुनेवाला छ हैन, तिमीहरुको चाहिँ हाम्रो interaction है. अब clinical postingहरु त हुन्छ नै होला, because clinical posting is very important. We need to teach you how to examine the ear, how to examine the nose, how to examine the neck, throat, everything. So that it may not be possible to do that on Zoom meeting. So regarding slides, I talked to the assistant who was here, and she told me that they are recording it. Okay, and maybe they'll prepare something. I know they'll prepare something, and they will give you some materials. But what you need to know is that what I have taught you here it is all from your book. Okay, there is nothing outside your book. So our bachelor level ma ke huncha, what happens in bachelor is we are more as a facilitator than a teacher, right? So we usually follow a textbook. So either follow Dhingra or you follow the Srivastava, and all the important things like I have highlighted, like Gratinescu syndrome, okay, or picket fence fever, and or Lux abscess, visual abscess, these words, okay. So it may not be possible for you to learn each and every word in the book, by your heart. So in the classes, in the Zoom meetings, we're focusing more on the most important things. Okay, acute mastoiditis with abscess formation. So whenever there is abscess, you drain it, right? Whenever there is abscess, drain it. But in acute mastoiditis without abscess, okay, Gaurav has asked me this question. We give antibiotics, and antibiotics for prolonged time usually treat acute mastoiditis. But suppose there is an abscess here, okay, retroauricular abscess. Then give an incision, drain it, and also give the antibiotics. Okay. In any complications of otitis media, antibiotics is a must, and along with that, we may or may not choose to include surgery. Okay, if the benefit of surgery is more than risk. Okay, gentamicin is an immunoglycoside that causes otitis. Can it be given complicated otitis media? Yes, it can be given. So we need to weigh all the drugs they have. Like they have side effects. They have some sort of toxicity. So we need to weigh the risk-benefit ratio. If the benefit is more than risk, we choose that antibiotic. And if it is if the risk is more, then we do not choose that. Okay, so it depends. Okay, sometimes the therapy, the medical therapy is tailored according to the need of the patient. Okay, the patient is the labyrinthitis ear is the ear that is affected, it is kept up. Okay, so whenever you admit the patient, okay, you give some sort of antibiotics. If the patient is not responsive, so you admit the patient not only for the treatment, the patient is also admitted for the workup, right? So the patient that cannot be sent back home, admit we give him antibiotics, right? But then we see the response of the antibiotic. So then we continue that. And meanwhile, just within that time, and we also get his blood profile done, and CBC got also, Bosco culture got also. We do so many investigations, and if the investigations, they point out to some other disease, some other complication, then we tailor make the treatment for that particular patient. And admit हुँदा चाहिँ as a first कुनै patient 10 days सम्मलाई admit हुन्छ, तर for the 10 days same medicineहरू चल्छ भन्ने छैन है, it changes condition हेरिकन. So that is about the antibiotics. So ठीक है, so what time your next class start? 9:30 or can pharyngitis lead to ear abscess? Yeah, sometimes that can lead, but that is very rare. Oh, okay. What is your next class? What time does it start? Let me see. I think it begins at 9:30, right? Okay. So your next class is, let me see, 10:30. Okay. It is already 10 o'clock. So from 10:30 to 11:30, you have psychiatry class. Okay, then students, now I need to go to the OPT because today is Sunday and there must be a huge number of patients. Okay, then shall I log off now, if you will permit? Okay, in the class, bye for today. So next ENT class will be on Tuesday. It will be taken by Tilak sir, and after that there will be another class on Thursday, and I'll take this class. Okay, then let me stop sharing.